Good evening. I'd like to welcome everybody. Again, my name is Dr. Joseph Maslak, a spine surgeon with the Core Institute in Novi, Michigan. I'm honored to be here, and I'd like to thank you all for taking the time out of your busy schedules to come hear my talk on understanding neck arthritis. I have no financial disclosures. A brief overview about what we're going to be talking about this evening. First, I'll introduce who I am, where I come from, and the training that I've received. I'll talk about spine problems in general, how I approach the patients, and what spine problems I take care of in general. Then we'll get to the meat of the talk, which we'll be talking about neck arthritis, aka cervical spondylosis, which is one of the medical terms, and I'll try to explain all the medical terms as we go throughout this talk. I'll talk about how arthritis develops, the symptoms that are associated with it. We'll get into the workup of arthritis and then the treatment options, both surgical and non-surgical options, and I'll be providing case examples as well. So a little bit about me. I'm Michigan born and bred. As you can see from my education and training, I have made my way around the Midwest a little bit, but I'm happy to be back home in Michigan. I completed my orthopedic surgery residency at Northwestern in downtown Chicago. And most recently, I completed a spine surgery fellowship at the Cleveland Clinic with both orthopedic and neurosurgeons. In my spare time, I love to cook. Like many Michiganders, I like to play ice hockey and golf, weather permitting. And when I do have free time, I like to dedicate that to my family. When I think about a spine patient, the first thing that I like to address is what sort of problem they're presenting with. The talk today is talking about neck arthritis, or a degenerative condition. We hear about arthritis, wear and tear of joints all over the body, from the shoulder, the hip, the knee, but there are joints in the spine as well, and they can develop arthritis when the cartilage wears out. And some of the medical terms that you may see are spondylosis, which is the term for arthritis in general, spondylolisthesis, which is when a disc slips on one another. You might hear it called a slip disc. Degenerative disc disease is a all-encompassing term that refers to bulging disc or arthritis in the disc, which are the cushions in between the blocks of bone that we call vertebral bodies. One of the less common but very debilitating conditions that I also treat are deformities. So scoliosis, which is an abnormal curvature of the spine, kyphosis, which is when patients develop a humpback deformity, and people can develop deformity after failed prior spine surgeries. I also take care of patients that present with traumatic injuries. And when I think about trauma, I like to divvy up whether it's a high energy injury, like a car accident or a fall from height, or a low energy injury, such as a fall from standing. And these can be split up depending on what type of tissues are involved, such as bone and or ligamentous injuries. I also take care of patients with tumors. And when I identify a tumor, it's important to define what type of tissue is involved, whether it's the bone, the nerve, the muscles. And it's important to define whether or not the tumor is primary, meaning that it's arising in the spine initially, or it's metastatic, a cancer arising from a distant place, such as the lung or the colon. I also take care of patients with infections. It's important to delineate whether or not this infection is associated with the prior surgery or it's spread in the bloodstream or the lymphatic system. Furthermore, when I'm dealing with spine pathologies, it's important to identify and delineate the location of the pathology. I take care of patients with pathology or disease everywhere from the skull all the way down to the tailbone. When we talk about occipitocervical disease, that refers to the head and neck region. Cervical disease refers to the neck, which is what we're going to be focusing on today. The thoracic spine is the portion of the spine that's connected to the ribs and the chest. The lumbar spine refers to the lower back, and the sacral bones are commonly referred to as the tailbone. I'll discuss the symptoms associated with neck arthritis, but when we talk about symptoms associated with spine issues, people can have back pain or axial pain, pain down the center of their back, whether it's in the neck, the thoracic region, or the lower back. people can present with radiculopathy or myelopathy or myelopathy, and I'll define those as we proceed. When you hear about patients having paresthesias, that refers to the pins and needle feeling that's affected when a nerve is irritated. Patients can present with numbness. They can present with weakness. Other terms that we use are sciatica, when there's shooting pains down the buttock and lower extremity, and neurogenic claudication. It's also important for me to define how long the symptoms have been present. Acute presentation means that the symptoms have not been there that long, and the patient is seeing me shortly after the symptoms have developed. There's also subacute and chronic problems. Chronic problems are often there for months, if not years. And it's important for me to define how long these symptoms have been affecting the patient, because that not only changes the workup, but it can change the treatment options as well. And then if you've had a prior spine surgery, sometimes if you need additional surgery, that's referred to as a revision surgery. In patients that have not had prior spine surgery, that's referred to as a virgin spine. And it's important for me as a spine surgeon to know if you've had any prior surgery. So that's definitely something that I discuss with every patient that I see. The types of surgeries that I perform all different types of surgeries from the cervical region all the way down to the lumbar spine. And there are different approaches that I can get to the spine from, whether it's an anterior approach through the neck or the abdomen, a posterior approach, which is referring to coming in from the back, a lateral approach, which refers to coming in from the side, or a circumferential surgery, which includes the front and the back. I perform both motion sparing surgery and fusion surgery. I perform minimally invasive surgery, although that moniker does have a debatable aspect to it. It can refer to using a microscope. It can refer to special retractors as seen below in this image. It can also refer to outpatient surgeries. So minimally invasive in and of itself doesn't necessarily define what I do, but I do perform those surgeries. There are emerging technologies that I also use, including navigation. Robotics is a technology that we'll see more and more of as spine surgery continues to evolve over time. And I also use 3D printed implants that more normally mimic the bone that we have in our body already. When it comes to defining what's a success versus a failure, this ultimately comes out to what outcome the patient experiences. And this is there's a lot of different things that play into this. One being the indications or the reasons that you're operating. Is there something that I can do anatomically that can make your symptoms better? Those are what refer to our indications. The expectations of the patients. I have to be able to tell you a realistic expectation of what could possibly happen, both including the good and the bad. And then technique. All these things play into the ultimate outcome for the patient. In my opinion, the most important thing out of all of this is the indications. That's why it's so important in the clinic for me to ask you questions, to perform a physical exam, to review your imaging, to be able to decide whether or not I can offer you something that's able to help you, whether it's surgery or not. So let's get to the meat of the talk. We're going to talk about neck arthritis, also known as cervical spondylosis. And this simply refers to age-related degenerative changes of the cervical spine. When we talk about the anatomy of the cervical motion segment, or where there's motion, because what arthritis is it's a degeneration of the cartilage in between bones at the joint. And joints are lined with cartilage, and when there's motion over time, the cartilage can wear out. So in the front is the intervertebral disc in between the vertebral bodies, which are the blocks of bone in the spine. Off to the sides, you can see there's also another space where that cartilage can wear out and you can develop bone spurs. It's called the uncovertebral joint, or the joints of Luschka. And then in the back, on both sides, there are two facet joints as well. And all of these areas of the cervical spine can degenerate over time, and they can cause problems. And I'll get into that. So because the intervertebral disc, or that cushion in between the blocks of bone, is made of 80% of water, this dries out over time. And you can see it's a circular, self-fulfilling prophecy almost, because as that disc dries out, it accumulates damage over time and you gradually lose height in the disc. The disc then bulges into the spinal canal and the neural foramen, or where the nerves exit the spine. And then your body's normal response is to try to repair this tissue. So the ligaments and the capsule, or the soft tissue surrounding these joints, hypertrophy or grow to try to protect itself. And then you can develop subluxation or mobility between the certain segments of the spine, and you can form osteophytes or bone spurs. And as a result, you can develop deformity, or the humpback kyphosis that I referred to earlier. And all of this further contributes to altered biomechanics, and the pathway continues to proceed. However, when folks present with radiographic evidence of arthritis, it doesn't necessarily mean that they're symptomatic. Studies have indicated that in a quarter of individuals under the age of 40, they have radiographic evidence of arthritis, even if they're asymptomatic. However, because this is an age-related degenerative wear and tear phenomena, you can see that in patients over the age of 60, 85% of individuals have been found to have evidence of arthritis on imaging. That doesn't necessarily mean they're going to be symptomatic, though. So that's a very important point that I'm going to reiterate throughout this talk. When we talk about the symptoms associated with neck arthritis, one of the most common things that I will see as a spine surgeon is patients with radiculopathy, and that simply refers to nerve irritation. The spinal cord can be thought of as a highway between the brain and our extremities, and the nerves are like the off-ramps, okay? That's when the signal comes from the brain, comes off of the spinal cord, and gets into the extremities, whether it's the arms or the legs in the lower extremities. And radiculopathy refers to nerve irritation. Myelopathy refers to the sixth spinal cord. So that's more of congestion in the freeway itself, okay? And I'll further delineate all of these. And then one of the more common things that is seen across primary care and orthopedic physicians, including spine surgeons, is neck pain. And Dr. Adam Lundberg gave a great talk with the Core Institute out of Phoenix in early August. I encourage everybody to check that out if you haven't seen it, where he focused on mostly non-operative treatments for neck pain. I want to reiterate that these are not mutually exclusive. So patients can present with all three. They can have a myeloradiculopathy with associated neck pain. They can have a radiculopathy with neck pain. They can present with just myelopathy. So these are not mutually exclusive. And when I'm interviewing my patients, I ask them questions about all of these different syndromes. We do know that symptomatic arthritis is the leading cause of radiculopathy and myelopathy. So nerve irritation and a sixth spinal cord, the most common cause of that is neck arthritis. Focusing on cervical radiculopathy for a moment, this refers to nerve irritation. The arthritic changes that result from the cascade that I showed earlier result in a decreased area for the nerves to exit the spinal cord and get to your extremities. They carry sensory and motor or strength information. When the arthritic changes happen, there's both inflammation and mechanical compression. As you can see in these images, the image on the right and the left are both cross sections, with the bottom of the image being the front of the spine and the back of the image being the top of the image being the back of the spine, or the facet joint. And inflammation refers to the body's response to something that's out of whack. So whether it's an infection or arthritis or a trauma, the body tries to clear out the bad stuff and stimulate a healing response by sending different cells and chemical signals to the area. And this can result in swelling. And so as you can see, there's both a chemical and a mechanical relationship to arthritis causing nerve irritation. When patients present with radiculopathy, the most common thing that I will see is patients with shooting arm pains. And usually it affects the distribution of the nerve that's irritated. But as you can see, folks can also present with sensory deficits, so numbness, or the pins and needles feeling, or the paresthesias that I discussed earlier. More often than not, patients also have associated neck pain. Sometimes they can have weakness, and sometimes they can have issues with their reflexes. So these are all things that I try to tease out when I'm doing a physical exam. As you can see with this slide, the different nerve roots that come out at different areas of the cervical spine affect different areas of the upper extremities and the neck. So when I'm doing a physical exam and I'm having patients squeeze my fingers or flex their bicep or lift their arms above their head, what I'm doing is trying to delineate how strong they are with each of these nerves. I'm trying to assess whether or not they have any asymmetric or just diminished sensation on one side compared to the other. And I also test their reflexes because each reflex is also associated with individual nerves. And there are other physical exam maneuvers that I will do, such as having you turn your head, flex to the side, and other things that I'll do that may not initially make sense, but the whole goal of this is to assess the health of those nerves. And I try to explain to my patients what I'm doing as I'm doing it. And if there are any questions about that, I encourage it during the exam. When we talk about myelopathy or spinal cord compression, this is a very different type of syndrome. Most often, these patients are not presenting with neck pain and shooting arm pains. In fact, it's very different. They most often present with an insidious or kind of a subacute onset of difficulty with their hands and difficulty with balance. And a lot of times it's hard for people to understand that this is related to their neck because a lot of their symptoms don't necessarily make you think of the neck initially. So people will present telling me that they have difficulty buttoning buttons, difficulty using keys and doorknobs, difficulty with eating utensils. They're clumsy in their hands. Sometimes a family member or a friend will notice that their balance is off, that they're swaying. They may look drunk. And I will tease this out when I'm doing a physical exam as well. So I will always watch my patients walk. I'll always examine their hands. And unlike cervical radiculopathy, spinal cord compression often presents with hyperreflexia, which means that your reflexes are very brisk. They're not weak. They're very brisk. Myelopathy, like I said, affects the hands more significantly than it affects the shoulder or the elbow. So a lot of times I mentioned the loss of dexterity, but sometimes people will lose muscle in their hand, and that's called muscular atrophy. They'll have difficulty with grasping, and there are other pathologic reflexes that I'll be examining. However, the most common presenting symptom that patients have to primary care physicians and orthopedic doctors is neck pain. Luckily, most commonly, this is not a problem that is going to necessarily need surgery. The most common reasons people present with neck pain are muscular strains, poor posture, or minor trauma. Localized superficial pain and tenderness is often suggestive of a muscular strain or soft tissue injury. Pain with flexion, or when you move your neck and chin towards your chest, is more characteristic of a myofascial etiology. And what the fascia refers to is connective tissue that envelopes muscle and separates layers of muscle, and this connective tissue can get irritated and inflamed as well. When people have discogenic pain that present with neck pain, that's often suggestive when people have pain that's aggravated by extension or looking up towards the ceiling and rotation of their neck. When we're doing workup for neck problems, most often the initial imaging study that we get is plain radiographs, also known as X-ray. If additional information is needed, we'll often get an MRI or a CT scan. However, it's important to note that when people present with cervical radiculopathy or the shooting pains, the shooting numbness and tingling, oftentimes this is self-limited in the majority of patients. So we frequently can go without getting imaging if these patients present acutely or within a few weeks of the onset of symptoms. Usually we can treat them with medications before having to do a large workup. However, there are definitely patients that have red flag symptoms, so to speak, that necessitate us getting images earlier rather than later. So if there's a relevant recent trauma, a fall, if there's fevers, chills, pain that's worse at night, an unexplained weight loss, if patients have a history of cancer, if people have progressive neurologic deficit or worsening weakness. These are all things that might make us want to get imaging right away. So not every patient has the same problem. So it's definitely important for us to ask these questions to figure out who needs to get imaging earlier and who we can treat conservatively before necessarily having to go down that route. When we get x-rays, on all my patients, if possible, I like to get standing x-rays, both an AP image from the front and a lateral image from the side. This can look at the alignment of the cervical spine, arthritis, and fractures. In some scenarios, we need flexion and extension x-rays where they put their chin to their chest or look up at the ceiling, and this assesses the stability of the spine and can look for fused segments of the spine. Magnetic resonance imaging, more commonly known as MRI, is the advanced imaging modality of choice if we need to look at the soft tissues of the spine. This identifies the nerves in the spine, the spinal cord, disc herniations, the ligaments, the joint capsules. It assesses the vertebral arteries and the vasculature. Because this study is performed while laying down, we can also assess the stability of the spine compared to those standing x-rays. However, I must reiterate that it's important to correlate these findings with the patient presentation. Just because you have something wrong on your MRI doesn't mean that it explains the symptoms that you're having, and it doesn't mean that a surgery is going to fix it. That's very important for everybody to understand. MRI, because it looks at the nervous tissue and the soft tissues, can see changes in the spinal cord itself. As you can see in this image, between the third and fourth vertebral bodies, behind it, the dark line is the spinal cord. And it's usually a nice gray color on this sequence of imaging. But you can see that there's a white, hazy discrepancy in the spinal cord with associated arthritic changes in the front. However, studies have shown that even these changes in the spinal cord don't necessarily correlate with prognosis or treatment consistently. But it's important for us to delineate and to educate our patients on this when we find these changes. CT scans can be thought of as x-rays stacked on one another. They're the imaging modality of choice to identify their bony anatomy. However, it is more radiation. There's more radiation with this because it's a multitude of x-rays being taken, and that's the risk. We often get CT myelograms where we inject a contrast dye around the spinal cord and the nerves. This is an invasive procedure, but we usually only get this if patients are unable to get an MRI or have prior instrumentation that make it hard for us to interpret MRI imaging. This is often done in patients with pacemakers or cochlear implants, among other issues. EMGs are another diagnostic tool that we use to assess the health of nerves and muscles and the muscles that they connect to. This can identify problems at the nerve level, the muscle level, or the connection between the two, and it's a useful diagnostic test. When we talk about treatment, I alluded to earlier, the vast majority of neck pain has a variable prognosis because it can be caused by a variety of different things, but the vast majority of it can be treated with non-operative or non-surgical options. And as I alluded to earlier as well, cervical radiculopathy or nerve root irritation has a favorable natural history, and it often resolves without surgery. However, myelopathy or sick spinal cord needs surgical decompression. That's not something that's going to get better on its own. As such, conservative treatment should be offered to all patients with new onset radiculopathy without any evidence of associated myelopathy or spinal cord issues. It's important to encourage your patients and to set expectations for recovery. As I alluded to earlier, expectations are an important part of the formula for outcomes or success. When we talk about conservative treatments for neck pain, massage refers to manual manipulation that helps break down muscular spasm, and this can increase blood flow to support healing. Heat is also useful to increase blood flow and may help with muscular pain. And ice is often useful after initial injuries as it reduces swelling and inflammation. Physical therapy is also a mainstay for patients with neck pain, both in the acute and chronic phase. And there's stretching, strengthening, and range of motion exercises that are taught to our patients. And these exercises should be learned and performed at home if at all possible. The American Academy of Orthopedic Surgery has publicly available spine conditioning program exercises on Google, on the internet, if you want to look for them. And I encourage folks to look at these if they want even a basic daily program to help keep their spine in shape. When we talk about pain medications, it's important to delineate non-inflammatory versus anti-inflammatory medications. So acetaminophen or Tylenol is not an anti-inflammatory medication. However, it is one of the most popular medications in this country for pain relief. It's important to note that you don't want over 4 grams or 4,000 milligrams in a 24-hour period, as there is an increase of risk of liver problems if that dosage is exceeded. Non-steroidal anti-inflammatories are among the most commonly prescribed medications in patients that are able to receive them. And these are over-the-counter medicines you may see in your local stores or pharmacies, such as ibuprofen or naproxen. There are also prescription strength anti-inflammatories like Celebrex or Mobic. And there are newer medicines such as Voltaren as well that are now becoming available over the counter. We tend to avoid these medications in patients that have kidney or GI problems, and there's also a very low risk of associated heart problems. So it's important when we talk to our patients about these medicines that we ask them about other medical problems they may have or other issues with these medicines they've had in the past. When patients present to me with cervical radiculopathy or nerve irritation, one of my favorite medicines to prescribe is a Medrol dose pack, and this is a steroid medication. Steroids are anti-inflammatory medicines. They're powerful medications. However, they're risky medications. But we know with studies, large studies with many patients, that a short course with low dosage has a minimal risk. And a Medrol dose pack, as I'll show you in the next image, is a low-dose medication with decreasing dosage every day. The risk with long-term use or large doses of steroids, it can cause infection, osteoporosis, diabetes, mood issues, high blood pressure, weight gain. And I don't tell you about these to scare you, but it's important for our patients to understand that there are risks associated with everything. And I have your best interest in mind, but it's my job to educate you as well. This is an example of a Medrol dose pack. Each of these pills are 4 milligrams. And you can see on the first day, you take 6 doses or 6 pills in 4 different doses. And then each day, this dosage decreases. So by the 6th day, you're only taking 1 of these tablets. Other medications that you'll see commonly prescribed include muscle relaxants. These help with muscle spasms with names such as Robaxin or Flexeril or Xanaflex. However, these also have side effects such as drowsiness and risk of falls. And keep in mind, this ultimately is not going to address any neck arthritis issues, but will help if there's any muscular neck pain associated with it. Narcotics are a hot topic in America today, given the opioid crisis or the epidemic. These can be useful for a short course for refractory patients in severe pain. Common medications that are used are Vicodin or Norco, or Percocet or morphine. And like I said, there are definitely scenarios where these medications are useful and indicated, but I think because it is such on the forefront of minds in America, both in the media and among physicians, it's important to have a conversation, a truthful conversation with any provider that is prescribing these medications to you. There's risk of drowsiness, nausea, constipation, but more seriously, especially when it's taken with other medications, there's a risk of respiratory depression and developing dependence over time. Other medications you may see are nerve stabilizers, such as Neurontin or Lyrica. This has a potential use in chronic neuropathic pain, but again, there are risks associated such as dizziness, drowsiness, swelling, and fatigue. And this is not very useful in the acute management of neck pain, in my opinion. Injections. Dr. Lumberg gave a great overview of injections, but I'll talk about it briefly here. Diagnostic medial branch block infections are when we inject local anesthetic or numbing medicine around the nerves that are around the joints in the back of the spine. It's a short procedure. It can provide temporary relief, but more than anything, it tells us that your pain is coming from the joints or coming from the nerves around those joints where there may be degeneration or arthritis. Epidural steroid injections reduce inflammation along irritated nerves, and these can provide relief in patients with severe symptoms. It's performed under X-ray guidance, but again, it's not a permanent solution, and there are very rare but serious risks associated with epidural steroid injections, but they can be a useful tool both diagnostically and therapeutically. Nerve ablation is a radiofrequency procedure where we heat or ablate small nerves that block the pain signals from small joints to the brain. This provides temporary relief because these nerves can regenerate, but the procedure may be repeated. And the role for this in treating neck pain is continuing to evolve and continuing to be studied. As I discussed a couple times already, the North American Spine Society, of which I'm a member, has a consensus statement about cervical radiculopathy or nerve irritation. It's likely that most patients with cervical radiculopathy from degenerative or arthritic disorders will be self-limiting and will resolve spontaneously over a short period of time without specific treatment. And what this means is that a lot of times if we treat your symptoms, the nerve irritation and the body will repair itself over a period of a few weeks to a couple months. So if you're presenting with cervical radiculopathy that's only been there for a couple weeks, I shouldn't be offering you surgery. Myelopathy is a different story. A classic study by Clark and Robinson have shown that patients with a sick spinal cord get worse over time. Oftentimes, I tell my patients that this is in a stepwise manner. So you may have a couple weeks where things are getting worse and then a couple months where things have stabilized. But over time, it gets worse. Over time is a stepwise deterioration. And a minority of folks, unfortunately, once they start developing symptoms, they go down more of a gradual slope downwards. But it tends to be progressive, and it can affect your function more than people can imagine. So again, when I talk about operative indications or reason that I offer surgery, myelopathy, a sick spinal cord, will get worse over time and will affect your function over time. The majority of patients with cervical radiculopathy will improve without surgery, but up to 25% of patients will have persistent symptoms and require surgical intervention. So my indication or the reason that I will discuss surgery with a patient are patients that have persistent symptoms for at least 6 weeks, imaging that correlates with the presentation of the symptoms, and those patients that have trialed and failed conservative management. It's important for patients to use these non-operative modalities that we have to see if we can get them through this episode of radiculopathy without surgery. You cannot undo surgery. The operative options that I'll discuss, this is a kind of progressive manner from the least invasive to some of the more serious surgeries that require more extensive rehabilitation. However, studies have shown that these operative options are good in providing relief in more than 90% of patients with radiculopathy. But because every patient is different, the amount of arthritis they have, the number of levels effective, where their arthritis is located, all the patients that I see are different. So my goal is to identify the correct surgery for each patient that provides the longest relief of their symptoms while minimizing the risk or morbidity. The least invasive procedure for treating arthritic irritation of the nerve is a posterior foraminotomy. So this is looking at the spine from the back, these images on the left, and the image on the top right is taking a cross-section through the spine. And what we do in a posterior foraminotomy is what's called a decompression, where we take pressure off of the nerve by taking away bone and soft tissue. There's no fusion, there's no instrumentation. Instrumentation refers to screws and rods and wires. A decompression is less invasive because we're not leaving hardware in that's ideally going to stay in for the rest of your life. A foraminotomy is taking bone and soft tissue away over the nerve, as you can see on the bottom left image. And we do this with a variety of instruments, including drills. But like I said, this is a successful surgery in the appropriate patients. Over 91% success rate in relieving the symptoms associated with that nerve root compression. However, it'd be great to be able to perform this surgery on everybody because it is less invasive. Sometimes it can be done as an outpatient, but when patients have arthritis and nerve root or spinal cord compression associated with central stenosis or stenosis from the disc in the front of the spine, or they have a hard disc herniation where there's calcification of a disc herniation, or they have multi-level arthritic changes or spondylosis, we can't necessarily do the least invasive surgery available. One of the gold standard procedures that we have is called an anterior cervical discectomy and fusion. As you can see on the right-hand side of the screen here, there's a horizontal incision through the front of the neck, and this is a decompression and a fusion procedure. So we take away the disc material and the bone spurs that are impinging and irritating the nerve or the spinal cord. And we also fuse those levels together. Because we have to take away all of the disc material, we have to fuse the levels together. And what a fusion refers to is taking away the motion in between the segments and having the bones heal and grow into one block of bone. So as you can see on the left here, the arrows pointing to the bony spacers are where the disc material has been taken away. And then in the front of the spine, there's a plate that's anchored with screws at each level into each vertebral body. So that is what an anterior cervical discectomy and fusion is. This also has a greater than 90% success in relieving radiating arm pains. However, there is a low risk of not fusing or developing adjacent level degeneration because you don't have motion in between the segments anymore. So as I'll show in a moment, we've developed other types of procedures. This is a patient this was a gentleman, 51 years of age, that presented to me with myelopathy. These are his lateral and AP x-rays. You can see a little bit of bone spurs and disc space loss, which would indicate arthritic or degenerative changes. But you really need to take a deeper dive, and we were able to get an MRI in this individual. And you can see behind C3 and C4, this patient had stenosis or narrowing of the spinal canal, the available space for the spinal cord. And he also had an associated signal change, the white haziness in the spinal cord behind C3-4. So we performed a one-level ACDF, C3, C4, and you can see that there's a plate in front of the spine on the image on the left, and that there's a bony spacer where the disc material used to be. And these are his post-operative x-rays. However, like I alluded to, the ACDF, because your fusing segments can have issues if the bones don't fuse together or if there's degeneration at adjacent segments. So we've, over time, developed a cervical disc replacement or an arthroplasty procedure. People more commonly know of arthroplasty referring to hips and knees and more recently shoulders. But as spine surgery evolves, we're improving our technology to be able to do this in the cervical spine. And this refers to an implant that has two metallic end plates, as you can see on the bottom right, with a polyethylene or a plastic core. And this ideally preserves motion in between the segments of the spine. So you're removing the risk associated with a fusion not happening or a failed fusion, and you're not having the adjacent segment issues because you're not having a fused segment below a mobile segment. However, the long-term results and lifespan are still unknown with these materials because it's a newer procedure, and we're continuing to improve this over time. There is an increased initial cost, but it's likely more cost-effective over time. And studies have shown that there's likely a decreased reoperation rate compared to ACDF. This is a schematic on the right of what the cervical disc arthroplasty surgery looks like. Again, it's the same approach as the ACDF. It's an anterior cervical approach, so it's a horizontal incision on the front of the neck. Ideally, this is approved for single or two-level symptomatic patients with cervical spondylosis or arthritis. However, we want minimal arthritis at other levels, so it's often in younger patients with good motion because we don't want the levels to fuse. We want them to be able to maintain the motion from the implant. So this is often not the average patient. Not everybody can get a cervical disc arthroplasty. And by get, I mean not everybody is indicated for it. This is a 42-year-old female who presented with bilateral arm pains, shooting down both of her arms. And this is her x-rays on the right and her MRI on the left. And you can see at C6-7, she has cervical stenosis and a bulging disc related to arthritis or wear and tear. So we performed a C6-7 cervical disc arthroplasty. The patient's symptoms improved almost immediately, and she was able to go home the day of surgery. These are her 6-month postoperative x-rays, and she's doing very well. So this is a good procedure, but again, the indications are the most important aspect of that formula in my mind. You have to make sure that you're recommending the most appropriate surgery to the patient. Laminoplasty is a different procedure. This is a posterior-based procedure, so the incision is over the back of the cervical spine or the back of the neck. This procedure is gaining popularity. It's a decompressive procedure. It's a non-fusion surgery, so you're maintaining motion. You're not fusing the bones together, but it is an instrumented procedure. As you can see, there's a plate and screws. And the whole idea with this procedure is we're hinging open the arc or the back of the spine that protects the spinal cord to give more space or expand the area for the spinal cord. So as you can see, as the images progress from the left to the right, we make a full thickness cut through one half of that bony arch or the lamina. And then on the other side, we take away some of the bone so that we're able to hinge it open. And once we have that bone hinged open, there's more space for the spinal cord, and we use a plate and screws to keep that space open. We can do this procedure on multiple levels, and because it's not a fusion surgery, you still have motion in the spine. This is a 58-year-old gentleman that presented with myelopathy, and you can see that he has degenerative cervical disease. He has a loss of disc height, and he's developing bone spurs in his spine. When we got an MRI, we can see that he has narrowing of his spinal cord between C4 and C7. And he presented with myelopathy. So the symptoms that he presented with they make sense with the imaging. So we offered this gentleman a laminoplasty procedure. And you can see on the x-rays, the left being the AP x-ray, the middle being the lateral x-ray, and the right being a special x-ray called the swimmer's view that gives us a little bit more information in the lower cervical spine. You can see that there are white metallic plates that are used to hold open the lamina or the arch in the back of the spine. So it looks very different from an ACDF or a cervical disc arthroplasty procedure, but there is instrumentation. Probably the most invasive procedure that we do for neck arthritis is a posterior decompression infusion. This is when we, as you can see from the schematic on the right, this is when we make an incision in the middle of the cervical spine in the back. We detach the muscles from the center of the cervical spine, and we actually take away the bony arch. Instead of hinging it open, we take away the bony arch and we fuse the levels together by putting in screws and rods to connect each level together, as you can see on the schematic on the bottom left. The fusion is used to prevent instability and loss of alignment, because when you take away that much bone, you don't have the stability that the bone provides, so you can develop kyphosis or the humpback deformity. And when we remove bone, it's often referred to as a laminectomy. This is a 78-year-old gentleman that has multi-level arthritic changes. He also has some congenital changes in his cervical spine as seen on his x-rays and some curvature of his spine. He presented with myelopathy. On his MRI, you can see that he does not have much space available for his spinal cord. And because of the curvature, things don't look as normal as some of the other cases that we have reviewed. This gentleman received a decompression infusion that went all the way up to his occiput or his skull. So you can see on the top of the left image, in the back of his skull, he actually has a plate and screws that anchor things together and connect to his cervical spine. And you can see the bend in the rod that comes all the way down to the top of his thoracic spine, and the screws that go into the bones in the back of the spine as well. I appreciate everybody taking the time here today, but I want to reiterate kind of the take-home points or the pearls of wisdom, so to speak. Spondylosis, you'll see in radiology reports, you'll see all over the internet, but it simply refers to arthritis or age-related wear and tear. It's very important to understand the medical lingo that we use. It's important. One of the biggest points that I want everybody to understand is that imaging changes don't necessarily correlate to symptoms. So it's important to take everything together and to understand that the imaging relates to the symptoms that you're having, because if it doesn't, then a surgery is not going to help you. Patients can present with a variety of symptoms. We discussed radiculopathy or nerve irritation, myelopathy or spinal cord compression, and neck pain. And people can present with a combination of these three. As such, a thorough workup is critical for diagnosis and treatment. Neck pain alone, fortunately, can most often be treated with non-operative conservative management. The natural history is favorable for cervical radiculopathy or nerve root irritation, but unfortunately not for cervical myelopathy or a sick spinal cord. As such, you can trial non-operative management in patients with cervical radiculopathy, but we do know that when patients don't get better and they have trial conservative management, that there are surgical procedures that can help them. And there are multiple operative options available with proven outcomes in the appropriate patient. And it's my job to have an honest and thorough discussion with you to figure out what's in your best interest. Because at the end of the day, like I said earlier, you can't undo surgery. This is your life at the end of the day, and I want to do everything I can to be able to help you. So thank you for your time, and this is my information if you'd like to come see me and have a chat. You want to keep your neck and range of motion. If you don't use it, you lose it, so to speak. But if it's painful, there's oftentimes a reason. And whether that's a muscular strain or a myofascial issue, it's important to treat those etiologies. When people develop arthritis over time, they do develop stiffness or decreased range of motion. But as you could see in the physical therapy chart and the protocol provided by the American Academy of Orthopedic Surgery, or the AAOS, there are neck stretching exercises you can do to maintain the range of motion that you do have. But if you're becoming very uncomfortable and having sharp pains, listen to your body. And if it's something new and something that's affecting your function, talk to your physician about it, and we'll see what we can do about improving those symptoms and keeping you able to do the things that you want to do. That's a great question. I do not treat pediatric patients, but I can promise you that if a patient comes across my way, or I hear of a patient that has an issue that I don't personally treat, that I will point you in the right direction, and I'll get you plugged in with the folks that will take care of you. So that's a great question. A back brace will not help with the pain associated with myelopathy. I usually use braces in the acute or short post-operative period in patients that have had large surgeries so that the soft tissues can heal. What I have found that neck braces, and particularly soft neck braces that restrict range of motion, can oftentimes make stiffness and problems worse over time. So it's important, again, referencing the first question, that you continue to try to use your neck if you're able to work on range of motion and stretching. But unfortunately, a neck brace is not going to address the cervical cord compression. So dry needling can help a select number of patients with neck pain. The studies are kind of up and down with it. There are studies that say that there's no difference between that and placebo, and there are studies that say that it does help people. The risk is relatively low with dry needling. So what I would tell folks is that if it works for you and you're feeling better from it and you can afford it and it's not too much of a hassle for you, it's worth pursuing. But in my experience, it's not something that I would necessarily request for my patients, but there are therapists that will use it, and especially if it helps, the patients will request that they continue to do it. So that's also a great question. It depends where that pain originates from. So there are cervical nerve roots that come from the spinal cord that come into the lower neck and into the back of the skull. And those nerves can be irritated if there's compression of those nerves in the upper cervical spine. So it depends where the pain is coming from, where it's going to, and what the imaging looks like. But what I would say is a lot of time that isn't necessarily coming from the spine. So I would imagine that a lot of people would try to treat that with other modalities before doing an aggressive spine workup. So that's a great question. That depends on the surgery. The case examples that I discussed range from outpatient decompressive only surgeries to large surgeries with lots of screws and rods that limit the motion and your ability to actually move your neck. So that depends on the surgery itself. In the smaller surgeries, especially when there's not implants or fusions, folks can get back to almost everything that they want to do. There will be initial restrictions in terms of lifting and bending for about 6 weeks after surgery while the tissues heal. And that's not only the soft tissues and the muscles, but also the incision itself. We want to make sure that we give those tissues time to heal so that we don't have any issues or any increased risk of infection. But there are surgeries where long-term you can get back to doing all the things that you want to do, yes. But there are surgeries, such as the bigger ones where we're fusing your head to your neck, or doing other types of fusions where you're not going to have the same range of motion, and there could be risk associated with especially contact sports and high energy injuries such as skiing or bungee jumping or a lot of things like that. But I expect most of my patients to get back to their day-to-day activities and hopefully getting back to the things that give them joy and happiness in life.